My name is Gharagozloo. I direct the Center for Advanced Thoracic Surgery at the Global Robotics Institute at the University of Central Florida and Advent Health Celebration. Today I'd like to discuss with you an important topic which has been neglected for many years, which is thoracic outlet syndrome and the role of robotics in really helping us understand this disease, and in addition, helping us treat this disease more successfully than the past. Instead of taking you through a journey of through this disease, which has really been discussed for the past 300 years with very really questionable results, it's important to understand that this is highly underdiagnosed. It's thought to be in about 8% of the population. It's usually a disease of younger people, usually females, 4-to-1 ratio. And unfortunately, since the 1950s, when a paper was written by Pete, this disease has been put into 3 categories. The neurogenic patients, frankly, it's better said that patients with nerve symptoms rather than neurogenic is the majority of the patients, about 95%. The arterial patients, 3 to 4%, and then the venous patients, which are about 1%. This really has caused a great deal of confusion over the years, and I'm certain that most thoracic surgeons, vascular surgeons, or other people who deal with this disease have always been very uncomfortable with what is going on and what is the diagnosis. The important point is that all tests for this disease have been inconclusive, and in fact, surgery has been used as a way of making this diagnosis, which frankly is counterintuitive. There's no test that can predict the therapeutic and surgical success of these. And most likely what happens in these settings, people avoid therapy. They resort to physical therapy, but frankly, at our present understanding, it is a contraindication in these patients who actually have the disease. And these patients populate pain clinics, and many times, unfortunately, they're even seeing psychiatrists because people don't believe the symptoms that they are experiencing. The important thing is that approximately 15 years ago in our program, we started with an open mind and a clean sheet approach, thinking outside the box about this disease. There were a number of questions. One question is what is the cause of thoracic outlet syndrome? The other is, what preoperative test best predicts the surgical outcome? The other is, how much of the first rib needs to be removed? Finally, what's the best surgical approach to remove whatever portion of the rib you believe is causing the problems, which we presently call the offending portion of the abnormally developed first rib. Our journey began with a patient who had neurogenic symptoms and had already undergone first rib resection by a transaxillary approach. The patient stated that the symptoms got a little bit better, but they were not gone. This is a very common presentation and understanding. Unfortunately, the surgeon swears that they took out the first rib, but the patient says, I got a little bit better. So there's a quandary here. And if you look at this chest x-ray, you can see that here's the first rib on the opposite side. You can clearly see that the first rib has been removed in this patient, yet there is a piece of the first rib that is present. The surgeons usually cut the rib just before its joint with the sternum and remove the posterior aspect of the rib. In this patient, frankly, we then proceeded with getting an angiogram. And if you look at an venogram, you can see that the patient, when he elevates his arm, the subclavian vein, which was normally flowing into the innominate vein and then into the cava, was then obstructed. That area of obstruction went along with this very medial portion at the costosternal junction. If you look at a skeleton, you can see that in this patient, based on these studies, the rib had been removed, but this portion, which really forms a joint with the sternum and sometimes the clavicle, was left behind. Given the new technology that we were dealing with, had undertaken robotics starting in 2003. We decided to look inside the chest of this index patient using the robot and seeing what was going on. The view was this. Here is the apex of the chest. This was the portion of the rib that was left behind. We then proceeded to remove this by disarticulating it from the sternum, thinking that that was going to open the vein. This is the piece, and you can see there is a portion of the bone that it would be sitting right on top of the subclavian vein. And we were curious about what this represented, but this was the cut edge from the previous surgery, and this is this articulation. Interestingly, the venogram on the patient postoperatively showed that the area of extrinsic compression was now gone, and the patient's symptoms disappeared. The patient had no more pain in that extremity. So we began with this observation and then added a number of patients who had neurogenic symptoms who presented with persistent symptoms after getting either a transaxillary or supraclavicular first rib resection, and yet had persistent symptoms. And by removing that portion that was left behind, these patients got better. This led us to question whether there was a similar situation in patients with Paget-Schroeder syndrome, in whom the compression of the subclavian vein is supposed to be causing the thrombosis and the syndrome. We had a total of 9 patients in this group, and I believe 11 patients in the other group. And by removing the portion of the bone that was left behind medially, we had excellent results in both groups of patients. The neurogenic patients, their pain went away. The Paget-Schroeder patients who had recurrent subclavian thrombosis, this should be thrombosis, they had open veins. That led to a study which was published in 2012 in the Journal of Clinical Pathology, where we compared the normal medial aspect of the first rib to patients who had resection of that area with good results. And we proposed the pathogenesis of this disease to be compression of the subclavian vein at the junction with the innominate vein because of an abnormally developed tubercle, in basically saying that in these patients, the joint is abnormal, it compresses the vein, and because of the venous compression, you can get Paget-Schroeder with thrombosis. And of course, because this is an end organ, meaning the upper extremity gets one blood flow through a artery and one venous drainage, by compressing the venous drainage, as is well known, you actually cause venous ischemia and symptoms that are nerve related, but they are not from compression of the nerve, but they're from venous ischemia. That was the pathogenesis that was proposed, and that was our working hypothesis with seeing these patients and gathering the clinical experience. This was published, as I noted, in 2012, and this started the concept of an ischemic venous ischemia causing compression, causing pain in the upper extremity from compression of the subclavian vein by the malformed bony tubercle. These are some 3D reconstructions in these patients preoperatively. You can see the first strip comes along, and this is the medial area, and this is where the disease is. In a normal patient, there would be a trough where the vein sits, and yet in these patients, this is abnormal and it compresses the vein. Now, it's very interesting that in these patients, this is also bilateral and congenital. In fact, when we did a study of patients who presented with unilateral symptoms and who were questioned about symptoms in the other side, it was very clear that the patient had more interest in the dominant side in terms of symptoms and attributed symptoms to the non-dominant side to something having to do with the musculoskeletal system. This is another 3D reconstruction. This is clearly an abnormal portion of the joint that's forming between the first rib, the sternum, and at times, depending on the size of the tubercle, with the clavicle. Then we devised at the University of Arizona a study that would allow us to diagnose that area of compression and look for that congenitally abnormal area of the bone. This is one of the early studies where this is an MRA, and you can see that in this patient, the left subclavian joining the innominate gets compressed with elevation of the extremity with an extrinsically seen shadow, which corresponds to that abnormal tubercle of the first rib. Here is a venogram showing where you would expect the compression to occur. And I'm going to play you a venogram, and you will see what happens in these patients as they elevate their arms. When they elevate their arms, the extrinsic compression of the subclavian vein at the innominate junction shuts off the flow, causes venous hypertension, decreases the perfusion of the nerves, and these are the patients who get neurogenic symptoms. These should be actually called nerve symptoms. Now, if they keep their arms elevated for a longer period of time, such as in a mechanic or a baseball player who's pitching constantly, you can see that prolonged compression can cause clotting of the vein, and then we call that venous or Paget-Schroeder syndrome. Both of these are the same disease at a different point in the spectrum. Here is the venogram in such a patient. You can see that the dye is coming in, the patient's arms are down, and the dye is flowing into the innominate veins. As the patient elevates their arm, all of a sudden, you will see that in these points where I'm pointing right here, there will be compression and no more flow, stagnation. The patient will say that with those movements, they get pain. And then, of course, if they keep it prolonged, then it will thrombose, and we would call that Paget-Schroeder syndrome. So what is the cause of thoracic outlet syndrome? As I said, our working hypothesis for the pathogenesis of this disease is that this is caused by congenitally malformed medial aspect of the first rib. The costosternal joint is abnormal. The bony tubercle presses on the subclavian vein at its junction with the innominate vein. The issue is that this most likely is the cause of both the neurogenic symptoms and the venous symptoms. And it is very important to understand that this is different than compressive things that occur in the cervical region relating to abnormal ribs and so forth. Now, the concept is there is ischemic pathogenesis versus what we have thought about for many years as a compressive pathogenesis. The proof, as they say, is in the pudding, and using this in our experience of over 150 patients who have either one or the other, what happens is that these patients, once you remove the abnormal portion of the bone, then the patients have a decrease in symptoms and actually resolution of symptoms. And in the patients who have Paget-Schroeder, the vein is open and can be basically ballooned if needed, but there is no problem. So the concept really that we are working with, which is even more important than the technical aspects of the surgery, is that in patients who have neurologic symptoms, the majority of them have vascular compression of the subclavian by that abnormal portion of the bone, and then they have venous ischemia, which manifests as neurologic symptoms, and that's why the nerve conduction studies are negative. That's why a neurologic exam is not able to show a specific nerve deficit. In a minority of patients who have neurologic symptoms of the upper extremity, they have cervical ribs with bands, which are well known, but that is a very small, probably less than 5% of the patients with neurologic symptoms have the neck problem. So if you get a neck X-ray and you rule out a cervical rib, then one needs to be thinking in these terms for making the diagnosis of TOS. Patients who have arterial disease or Pete's arterial classification, those patients actually have arterial compression in the neck. They really are not a thoracic outlet type patient. They actually have compression of the subclavian artery in the neck by bands, etc., related to abnormalities of the cervical vertebral processes and cervical ribs. And then the venous patients by Pete's classification are really the same patients as the ones with the neurologic symptoms. In fact, if you study these patients and question them about neurologic symptoms prior to the occlusion of the subclavian vein and Paget-Schroeder and thrombosis, they would report that they had neurologic symptoms, but they attributed them to something else. So, in our view, this disease should be really thoracic outlet syndrome is most of the time subclavian vein compression syndrome, presents with neurologic symptoms, and if you keep occluding that vein too long, you get thrombosis, and then we call it Paget-Schroeder. Cervical rib syndrome is a different disease. And I think that by clarifying these two different things, we're able to get much better results for our patients and better understand the way this should be classified. So what preoperative test predicts the surgical outcomes, which is really the key? Well, you do a cervical study with x-rays if you rule out the cervical rib disease and if you rule out all other neurologic conditions. Then you get an MRA with maneuvers. This study is not an MRI, an MRA with maneuvers, which is 100% specific for showing you the disease of the first rib, that tubercle, which causes compression of the subclavian vein. Here is an MRA. You can see this side is worse than the other side. Subclavian is coming, the arms are elevated, and the vein stops right there. That is extrinsic compression from a bony tubercle on the first rib, what we call the offending portion of the first rib. The rest of the first rib has nothing to do with this disease. This is another one. You can see this time on the right, it's worse, and it comes out with elevation, which now should make sense why mechanics clot their arms, why baseball players clot their arms, anyone with prolonged activity with the arms raised and motion. What is the best surgical approach to remove this offending portion once you've made the diagnosis? Well, we believe that the robot is the key. The robot allows us to get to the offending portion very easily and remove it. Due to time constraints, I think it is best to pay attention to this YouTube video, which is one of our videos that kind of outlines how the operation should be done. And we've had excellent results with this surgery. And frankly, the results in the patients just keep the patients coming. The important thing is, this is a view of a patient's chest. Their upper part of their chest in these patients is abnormal. The first rib starts to turn in very quickly. I apologize, we'll go back. And the disease is right here. You can see how large this mammary vein is. These veins are all acting as collaterals because the subclavian that's coming in, which is on the other side of this bone, is obstructed with elevation of the arm. The disease is right here. This has to be opened, and you have to disarticulate it from the sternum and sometimes the clavicle and remove it. And what is done is we basically will divide the rib right where the subclavian artery goes over it and remove the medial aspect. This can be seen very easily in the video that I showed you the reference to. Our initial experience was published in Innovations with patients with Paget-Schroeder. There is a CTS-NET presentation that the audience can look at for understanding how the surgery is done. The longer-term experience in our patients was reported in the European Journal of Cardiothoracic Surgery in patients who had Paget-Schroeder syndrome, and in the recent paper in the Surgical Technology International, we showed the results with neurogenic patients. And finally, if there is interest in the audience, the second edition of the textbook of robotic surgery with these editors will be available from Springer in November 2020. And there is a very extensive chapter on the history of thoracic outlet syndrome, what we're thinking about it, what some of the newer thinking is all about, and frankly, how the new thinking is changing the surgery results, and how the robot is really playing a significant role in allowing us to treat these patients appropriately. The important point about the robotic approach is that in our experience, the offending portion of the first strip cannot be removed using a transaxillary approach, a supraclavicular approach, and so the robot allows us to get to that very small area, remove the bone, disarticulate it with excellent results. Thank you very much for your attention.